question, I highlighted in red and enclosed in a red box the important points that I would like to stress. For the outline of the discussion, first I'll be presenting the case and my clinical impression, and then I'll be discussing the differential diagnosis for the case, and then the laboratory exams that I would like to request, and my management plan for the patient, and lastly, the concept map of this discussion. So let's go with the case. We have here a 57-year-old man who came to the outpatient department with the chief complaint of cough and difficulty of breathing. History of present illness revealed that the patient was apparently well until 2 weeks prior to consultation when the patient noted productive cough with whitish phlegm. However, there were no associated symptoms like fever, difficulty of breathing, chest pain, and chest heaviness. Interval history revealed the persistence of productive cough with whitish phlegm, with no other associated symptoms, until 1 day prior to consultation when the patient noted easy fatigability, chest pain, nausea, and weakness. However, there were no associated symptoms such as palpitations, edema, orthopnea, nor paroxysmal nocturnal dyspnea. It is important to note in the past medical history that our patient has no comorbidities like diabetes, hypertension, COPD, coronary artery disease, kidney disease, stroke, or cancer. Patient was never hospitalized and he has no allergies into food or drugs. There were no past surgical operations done in our patient, and in the family history, patient's father is hypertensive and had an episode of stroke. There is no family history of coronary artery disease, diabetes, cancer, asthma, TB, and kidney disease. As for the social history, it is important to note that these risk factors are not present in our patient. Patient was a former farmer who is a non-smoker and a non-alcoholic beverage drinker, and he denies any recent history of travel. As for the physical examination, in the general survey, this indicates that our patient is stable with no altered mental status of acute onset. And it is important to note in the vital signs that all values are normal. There is a febrile, there is no tachycardia, there is no tachypnea, the BP is normal, and the oxygen saturation at room air is also normal. Skin findings were also unremarkable. The HCNT findings were unremarkable as well. However, we have to note the chest and lungs findings in our patient. This is very critical and important for our differentials. So it is symmetrical chest expansion. There is no retractions. There is dullness and increased tactile frenitus over the left lower lobe. There is bronchial breath sounds and crackles over the left lung base. As for the heart, this is also important to note that it is unremarkable, so that we could no longer associate the chest pain that the patient is having to any cardiac pathology. And as for the abdomen and extremity exam findings, both are also unremarkable. So my clinical impression for this case is lower respiratory tract infection to consider community-acquired pneumonia, low risk, probably bacterial in origin, rule out COVID-19. Here are the bases for my clinical impression. The patient has an acute cough for 2 weeks. An important risk factor that we have to consider is the patient's age, which is 57 years old. And older age individuals are more likely to contract pneumonia. And in light to what our country is experiencing right now, the COVID-19 pandemic, it is good to rule out viral etiology of his infection. For the low-risk community-acquired pneumonia, upon PE, our patient did not present any systemic symptoms of infection, like fever, tachypnea, nor tachycardia. And also, the patient is stable and has no comorbidities as well. The strongest PE to support pneumonia is the chest and lungs findings as follows. In other PE, findings were unremarkable, not pointing to any other underlying pathologic mechanisms like cardiovascular, gastrointestinal, or any other organ systems. So community-acquired pneumonia is the leading cause of death from an infectious disease. Actually, it is the sixth leading cause of death overall, and it is major cause of morbidity and mortality. Here is my basis for the low-risk category of our patient from the clinical practice guideline of our country. As you can see in this slide, any of these 8 parameters were not present in our patient, from the vital signs, having stable and normal vital signs, from the PE, no altered mental status, and for the history, patient has no suspected aspirations and no comorbidities as well. So our patient belongs to this category, the low risk cap, and could be treated as an outpatient. So here's the source or basis of my presentation for today. The Community-Acquired Pneumonia Clinical Practice Guidelines entitled Diagnosis, Empiric Management, and Prevention of Community-Acquired Pneumonia in Immunocompetent Adults, a 2016 update. Here are the different differential diagnoses, the bacterial pneumonia, and the COVID-19. I present to you a table comparing the patient's signs and symptoms to the two differential diagnoses, the bacterial pneumonia and COVID-19, and I arranged it from the strongest to weakest points that would support this differential diagnosis. So I consider this physical finding as the strongest basis uh, for bacterial pneumonia and COVID-19. Bacterial pneumonia could have clinical signs of pneumonia that could be mild or even absent, and COVID-19 could present with these lung findings. Both differential diagnosis falls under the category of an acute cough, and the absence of fever could still support the two, as the low grade or absence of fever present in bacterial pneumonia and low to high grade or even absent in COVID-19. For the age and gender, older age patients are commonly affected with bacterial pneumonia, and an important risk factor for COVID-19 would be an old age and the male gender. They are more predisposed according to the recent studies. And no history of travel could still be important basis for bacterial pneumonia, as this could still be present in this case. And we all know that there's already been a local community transmission recorded in the Philippines and even in our city. The following supports that our patient is stable from being having no respiratory distress, having normal vital signs, and other PE findings essentially normal. And CAP low risk essentially presents like this. As for COVID-19, it could clinically present as mild, common cold illness to severe viral pneumonia. However, it's important to note that it could be asymptomatic as well. And other points here that I consider as weakest, these are important risk factors that could predispose the patient, such as having a comorbidity, being a smoker and an alcohol beverage drinker. However, even though these are not present in our patient, it could still be a manifestation of CAP low risk and COVID-19. For the laboratory exams that I would like to request, here are those. First is a chest X-ray (PAL), a complete blood count, gram stain, and culture of sputum. And according to the Philippine Society for Microbiology and Infectious Diseases, for low-risk suspected COVID-19 patients, there are no diagnostic tests needed to request. As you can see in this table, patient falls under the low-risk mild disease with mild symptoms, and patient also has no comorbidities, so baseline diagnostic tests are not needed. For the chest X-ray, PAL, I requested this because this is essential in the diagnosis of CAP in assessing the severity, differentiating pneumonia from other conditions, and for prognostication. And also, the best radiologic evaluation is the standing posterior, anterior, and lateral view of the chest. So here's an expected finding for our case, a left lower lobe consolidation pointed by the yellow arrows. For the complete blood count, I requested this to establish the etiology of pneumonia, if bacterial or viral, and also to establish a baseline blood picture of our patient. Here are the expected findings for viral pneumonia. The WBC count could be normal or elevated, but it is usually not higher than 20,000. And for bacterial pneumonia, this is often associated with elevated WBC count with the predominance of granulocytes, ranging from 15,000 to 40,000. As for the gram stain and culture of sputum, I requested this because it could help in identifying certain pathogens like Streptococcus pneumoniae, Staph aureus, and others by their characteristic appearance. And for us to consider that the sputum sample is adequate for culture, there should be greater than 25 neutrophils and less than 10 squamous epithelial cells per low power field. And the greatest reason why I requested this is because uh, I have to be alerted for the unsuspected and or resistant pathogens and to permit appropriate modification of therapy upon encountering such. And here are the expected findings for gram stain and culture. As you can see here, this is a list of the most likely etiology for low-risk CAP. So it includes Streptococcus pneumonia, Haemophilus influenza, Chlamydophila pneumonia, Mycoplasma pneumoniae, and Moraxella catarrhalis. What I would like us to focus on is the Streptococcus pneumonia, as this is the most common etiology for bacterial pneumonia. So it usually presents as a gram-positive lancet-shaped cocci, elongated, with slightly pointed outer curvature, and it is usually in pairs. So this is how it would present in gram staining. And as for the culture, it is alpha hemolytic bacterium. For the management, my general plan for the patient is to treat him as an outpatient because the patient falls under the category of low risk CAP, and to advise strict home isolation for the observation of the disease progression and prevention of the spread of the disease, and to follow up after 1 week to check the response of the patient to the management plan. For the specific plan, I would give the patient an empiric antibiotic, azithromycin 500 mg, one tablet once a day for 3 days, taken with meals. This is for better compliance as it is once a day prescription. Azithromycin falls under the macrolide class of antibiotics with a mechanism of action that inhibits RNA-dependent protein synthesis by binding to the 50S ribosomal subunit, preventing the translocation of peptide chains. And the adverse effects that our patients should be alerted of are GI disorders such as diarrhea, vomiting, abdominal pain, and nausea, and the musculoskeletal arthralgia, nervous involvement of headache and dizziness. As you can see here, pointed by the cross mark, this is where azithromycin would act on, the 50S ribosomal subunit. This is the basis of my choice of antibiotic treatment. As you can see here, based on the Philippine Clinical Practice Guideline for pneumonia, here are the recommended antibiotics, empiric antibiotics, and our patient falls under the low risk cap without comorbid illness. And we could give amoxicillin or extended macrolides. And azithromycin is an extended macrolide. For the duration of treatment, my basis for 3 days prescription would be this, according still to the clinical practice guideline for uncomplicated bacterial pneumonia, we could give 3 to 5 days for strep pneumonia. For the therapeutic plan, I would give N-acetylcysteine, flumivasil, 200 milligram sachet to be dissolved in a half glass water 3 times a day, and also taken with food. This would dissolve the thick mucus of our patient, and this drug falls under the mucolytic class, and the mechanism of action is through its free sulfhydryl group, which would open up the disulfide bonds in the mucoproteins, lowering the mucus viscosity. And the adverse effects that we have to advise our patient about are here. Vomiting, nausea, arthralgia, convulsion, hypersensitivity reactions, rashes, hypotension, and wheeze. As you can see here, the mechanism of action of acetylcysteine that would lead to improved mucociliary clearance and reduce mucus secretion. For the patient education, I would advise my patient to take adequate fluid intake, at least 1 to 2 liters a day, and to practice respiratory hygiene measures, such as the use of hand hygiene and tissues to reduce the risk of spread, and to follow strict medication compliance. And also, I would advise healthy lifestyle through aerobic exercise at least 30 minutes every day, and healthy diet, including more on fruits and vegetables, low salt, low fat diet, and avoidance of alcohol drinking. Also, I would advise the patient to return immediately to the ER as soon as possible if the symptoms worsen and further aggravated dyspnea. As for the home self-quarantine instructions, I got this from UP Manila, COVID-19 updates. I would advise my patient to stay at home except when getting medical care, to separate himself from other people inside the house, and to avoid sharing household items like utensils and towels, and also to practice proper hand washing at least 20 seconds, and to use tissue in coughing and sneezing, and to always wear a face mask with the colored side facing outward, and also to monitor the symptoms like fever and the productive cough, and difficulty of breathing. So lastly, I would discuss to you the concept map of this presentation. So this is a general overview of what I presented to you. So here at the top is the pathophysiology, and at the sides would be the diagnostics and the treatment. Let's go through each one by one. Let's focus first on the pathophysiology. As you can see here, the important risk factors that we have to consider in this case is the age and the gender. Our patient is an elderly male, and according to Harrison's, elderly people have diminished cough and gag reflexes. Also, they have decreased antibody and toll-like receptor responses, leading to an impaired host defenses that would now allow the increase in multiplication of the pathogen in the alveoli. And this would now result into inflammatory responses by our body. The release of interleukin-1 and tumor necrosis factor would lead to fever. However, this is absent in our patient. because he is an elderly. And according to Harrison, the cytokine production of an elderly is diminished. So fever would not really present even in severe infections. The release of interleukin-8 and granulocyte colony-stimulating factor would now stimulate the release of neutrophils, leading to leukocytosis and increased purulent secretions, as presented by the patient with productive cough with whitish phlegm. The inflammatory mediators of macrophage and increasing neutrophils would lead now to alveolar capillary leak. This now is the reason for the manifestation in PE of dullness, crackles, and increased tactile femmitus and bronchial breath sounds at the left lower lobe. And lastly, the inflammation of the pleural lining of lungs and chest cavity would result to pleurisy manifested by our patient as chest pain and cough. All of these inflammatory responses would lead to increased respiratory drive, and then that would now cause the easy fatigability of our patient, and that easy fatigability would progress to nausea and weakness, and all of this would now result to dyspnea. Leading to our community-acquired pneumonia presentation as low risk. Go now to the treatment, the diagnostics. So I requested chest X-ray, PAL, complete blood count, gram stain, and culture of the sputum. For the treatment, general plan would be to treat the patient as outpatient, seek home isolation and follow up after 1 week. And as for the specific plan, azithromycin, this would target now the pathogen, the multiplication, and this would lead to the eradication of the pathogen in the alveoli. And the next, therapeutic acetylcysteine, this targets the increased purulent secretions by the patient so that the patient could easily secrete or expectorate the mucus. And here is the patient education to take adequate fluid intake, respiratory hygiene measures, strict med compliance, healthy lifestyle, and to return to ER if he presented with worsening symptoms. So here are the references for my presentation. And before I end, I would like to greet Dr. Dominguez, a belated Happy Mother's Day to you, Doc. And we really appreciate this great opportunity of alternative learning with you. We thank this effort of yours. We really appreciate it, Doc. Thank you so much. Uh, that would be all, and that ends my presentation. Thank you for listening.
Okay, thanks, Denmark. Thank you muna dun sa belated greetings. I appreciate that greeting and your appreciation, of course, appreciation ng group. Okay, so can you hear me?
Yes, Doc.
Okay. We have 7 minutes for Q&A. Before I ask questions or give my comments, are there any questions from the group? Hello? No questions? You could, if ever, you could also use the chat box, portion if you have questions. Okay, so while we're waiting, can you hear me?
Yes, Doc, yes.
Okay, so while we're waiting for questions, so very good presentation. You set the bar high. Your presentation was very targeted, complete, and you correlated. You had very good clinical pathologic correlation. Okay. So for your differentials, I would agree with your differentials. No, you had very strong basis. No question on that. For your diagnosis, so your immune impression was CAP-LR and then rule out COVID-19. your diagnostics. Wait, before we go to that, uh, in patients whom you think to have community-acquired pneumonia, especially in a patient who is coughing and complains of dyspnea, it's very important to do a chest X-ray right there and then, because that will help you classify whether this patient is really low risk or moderate risk. If you will see in the 8 parameters for pneumonia, the last parameter is chest X-ray findings. And this is very important because it will change our management if ever the patient has findings of lobar pneumonia or abscess or pleural effusion, which if let's say pleural effusion in its mild form, we can only see it on chest X-ray. So before we make a conclusion of CAP low risk, it's very important to do a preliminary chest X-ray. So that's one. Second is, again, your impression is CAP-LR, and you requested for gram stain and culture sensitivity. So if you go back to the guidelines, no, since it's low risk, okay, we don't need to do these procedures anymore, gram stain and culture and sensitivity for CAP low risk. And then also for COVID-19, you said that there are no tests done, but here, of course, we have to document whether this patient has COVID-19. So I think an RT-PCR would be in order here because the patient has similar manifestations with COVID-19. When you say no tests, even if this patient has mild COVID-19, a test, RT-PCR is indicated not only for the patient, but also for contact tracing, especially those who were in contact with him. And then for your treatment, so very good. Actually have no question in terms of treatment, and very good that you also mentioned the mechanisms of action of your drugs in your concept map. I would like to commend you on that. You were able to correlate very well the signs and symptoms and the treatment with the pathophysiology. Probably for the others, you could also try correlating the diagnostic tests with the pathophysiology. For example, you can connect the chest X-ray to the what happens in the lungs, no? The alveolar interstitial inflammation and exudation. You can connect the chest X-ray there so that you will know the reasons for requesting these tests. Okay.
Okay.
Okay, now in Denmark, you were able to take note of those comments?
Yes, Doc. Thank you so much, Doc.
Okay. So, any questions from the others? We have 3 minutes.